Hello and welcome to King's podcast, The Wellness Dive. I'm your host, 𝘸𝘪𝘵𝘀. Today we're joined by Dr. Gavin Spence, consultant pediatric orthopedic surgeon.
Thanks very much, Esther. Pleasure to be here.
And we'll be talking about fractures in children. Welcome, Dr. Spence. If you could introduce yourself to our listeners and what it is that you do here.
Sure. Thanks, Esther. Graced is a big word. It's my pleasure to join you on. I think this is the first podcast.
It is the first episode, yes.
All right, fantastic. So no pressure then.
No pressure at all.
Okay. So thanks for the introduction. So I'm an orthopedic surgeon, so I treat bone and joint problems, but I specialize in children. And that has been the case since I've been a consultant for the last 15 years. And my mother is keen on reminding me that when I was a medical student, I said I wasn't sure quite what I was going to do, but one thing I was damn sure of, and that was I was not going to treat children. And here I am. So, but I wouldn't have it any other way. And that's what I do here at King's.
That is great. The children are happy to have you. Where did you start your practice before you came over to King's?
So before I came to King's, I was a consultant in London. I worked in two of the big teaching hospitals there. The first was the Evelina London, which most people haven't heard of, but they probably have heard of Guy's and St Thomas's Hospital. It's part of that, right opposite the Houses of Parliament. As central London can be. So I was there for, I think, 5 years. And then for 5 years, I was at Great Ormond Street Hospital, which was the original children's hospital in London, treating rare, weird and wonderful conditions. And I was principally interested in correcting deformities, limb lengthening. It was a fascinating hospital to be at, actually. The patients were absolutely amazing. It was a good experience.
You mind telling us which are the most common cases you see here at King's?
Here at King's, the cases I see are not cases at all. They are children who are normal, but whose parents are concerned.
Really?
Believe it or not, that is the biggest group of patients I see. So these are normally young children with concerns. They're normally things like walking with their feet pointing in, or leg pains at night, or flat feet. That's a very common one. And I'm not saying all of these things are not necessarily a problem, but in the vast majority of kids, this is nothing to be concerned about. So perhaps surprisingly, I spend a lot of my time trying to do my best to reassure parents that there is nothing to worry about. And in between all of that, there is the odd child who really does need my help.
So basically you spend more time reassuring the patients more than the kids.
Yes, I think you could say that. The kids are generally unconcerned. It's important to work out who is the patient in the room. Is it the child? More often it's the parents, actually.
All right, lovely. Let's move on to fractures now. How would a parent know that the child has a broken limb?
Yeah, it's an interesting question because there is a lot of myth and rumor out there. For example, well, there's no bruising, so it can't be a fracture. Or, you can walk on it, so it can't be a fracture. Or, they slept through the night, so it was okay. Or you can move your fingers. All of these things are not true. And put it this way, when I see a child who I think might have a fracture, there's only one way I can tell for sure, and that's by doing an X-ray. And I have a low threshold for doing that, because I have learnt over the years that fractures can be surprisingly subtle, particularly in children. Sometimes they're obvious. So if a child has had a fall from a height and their leg now looks different to how it was, it looks deformed, well, it doesn't take a genius to work out that that's broken and they need to go to hospital. We do the X-rays and then we decide on the treatment. But often there is a scenario where a child has had a relatively minor fall at play, usually. So, for example, a 2-year-old coming down a slide lands a bit awkwardly when they've come off the slide and then are limping. Is that a fracture? But some people would say, well, no, the child can walk, it only just came off a slide. But you'd be surprised. That's actually a very common mechanism for getting a fracture of the shin bone. Mm-hmm. So, and I should say a fracture and a break to us are the same thing. Uh-huh. To a lot of parents, they think they're different things, probably because, to an engineer, a fracture just means a little crack. But to us, it's the same thing. Uh-huh. You've got to have a low threshold for investigating with X-rays, and that's what I do.
Speaking of small fractures, what if a parent doesn't notice and the child, let's say, they cannot express themselves? What would be the long-term repercussions of this going unnoticed?
Well, that depends on the fracture. So we might get on to talk about that later, but it's a bit of a specialist job knowing about children's fractures. They come in all these different shapes and sizes and severities. Some are very obvious. Some look like almost nothing, and are often dismissed on x-rays as being nothing to worry about. Whereas actually, if you know what you're looking for, there's a serious injury there. So here's the good news, I guess, that the vast majority of children's fractures are going to heal and heal well without the attention of any doctors. And if you think of, animals out there in the wild, they're breaking things all the time. They don't have orthopedic surgeons seeing them. So with a few exceptions, actually, even if we don't diagnose a fracture, odds are things will be fine. And if I think back to my own childhood, which was a happy childhood, I should say, but I think back to the number of times I thought I had a bruise, or my parents thought I had a bruise. I don't think, now knowing what I know now, that was no bruise. That was a fracture. I'm okay, by the way.
Oh, okay. Good to know. Good to know. You look okay.
Yeah.
So is there a difference between fractures in children and adults?
A lot of differences, yeah. Completely different ball game. So the most obvious difference, I guess, is that children's injuries heal real quick. So roughly half the time that adults take to heal, and they heal reliably. The chance of it not healing, very small. So that's one of the differences. Another difference is the mechanical properties of bones in children and adults are quite different, and that means they get different fracture patterns. So you or me, we have bones, I guess, more like this china cup. So that cup, if you really leant on it with a lot of force, nothing would happen until you reach a critical point and it would suddenly shatter. Mm-hmm. Whereas children's bones, I guess they're more like these twigs that you see here, these green twigs. They're more pliable. They're more likely to deform and to crumple. So that's another difference. So they heal quicker and different fracture patterns. And of course, the third real important difference in a child's skeleton is that it's growing. And there are good and bad points to that. The good points are that because the child is growing, we often don't need to get exact perfection in the alignment of the fracture, unlike in adults. Because they have this process called remodeling, it means that as the bone heals, let's say it heals at a bit of an angle, but as the child gets bigger and the bone grows, nature actually straightens the bone out for us, which is great. That doesn't occur in adults, at least not to the same extent. Mm-hmm. That's a good thing about being a growing child. Mm-hmm. But the bad side of it is that fractures can affect growth. So even if they then go on to heal, then there's a chance that growth could be disturbed and the child could end up with one leg shorter than the other, or that as the years go by, it starts to grow off at a funny angle. Mm-hmm. So again, that would not happen in adults. That's a consequence of growth. So pros and cons. Mm-hmm. And I suppose the final difference is that the x-rays look very different in children to adults. So you have to know what you're looking for. And to the uninitiated, particularly I'm thinking of elbow injuries, you've got to be careful because things that you see on the x-ray you think are abnormal might be very normal. It's just where the growing areas of the skeleton look a little bit like fractures. On the other side, if you get a fracture through these growing areas, the signs can be very subtle. So without going into detail, it can confuse doctors. So you need to know what you're talking about.
Let me take you back to the stunted growth of the injured leg. If caught in time, can it be fixed, or the child is just going to have one longer leg than the other?
If there is permanent damage to the growth of the limb, then the odds are that this child is going to need some sort of treatment to sort that problem out. The good thing is that we have lots of techniques now to do that. It all involves surgery, but some surgery fairly minor, some is fairly major. But our techniques of dealing with things like one leg shorter than the other have really been transformed certainly in the last 10 years. We have equipment to deal with that problem. In that scenario, if that happens, what we try and do is to make a prediction about what we think is going to happen to the child if nothing were to be done. So if it's actually going to be a very minor difference in length, sort of under 2 centimeters when they're fully grown, that might not need treatment at all. Okay. But if it's going to be bigger than that, then we do have lots of options to correct that by the time they're fully grown, yeah.
Okay, that's good, that's good. So if there are parents out there, they should know all hope is not lost yet.
Absolutely, yeah, all hope is definitely not lost.
Now, if a child has a fracture, do you think they may need some extra dose of supplements, for instance, calcium?
Yeah, this is a question that parents often ask me. And again, let's think back to the animals in the jungle who fracture things and heal and go on to heal without the help of doctors.
Without going to the orthopedic office.
Without going to the orthopedic office. So what does that tell us? It tells us that nature heals these things up more frequently than not. And if there was a supplement that I could give that would make fractures heal quicker, I wouldn't be sitting here talking to you now. I'd be driving a Maserati, and I would have been retired years ago because of the money I would have made. So actually, with a few exceptions, children don't need any extra supplements. They just need the normal diet. That said, in this part of the world, we're all short of vitamin D. So I know a lot of children are routinely supplemented with vitamin D. And I guess if that's your thing as a parent, then carry on with that. But most children don't need any special supplements, no.
All right, doctor. There's something I've been wondering about when we decided to feature this topic on fractures. So we have children come in different ages, yeah? If they have a fracture and you put on a cast, how do you keep them still, especially the 𝘸𝘪𝘵𝘩𝘦? Are they supposed to stay still, or are they supposed to continue playing as if everything is normal?
It's a great question. It always makes me laugh when I see children who've been treated, usually by fairly junior members of my team, and they have a 2-year-old, and they've said to the parents, you must stop the child from walking. It's like, you clearly don't have children of your own. It's not going to happen. It's more like veterinary practice with very young children. You cannot expect them to do anything other than what they feel happy doing. If the child feels okay to walk in their cast, they will. That affects our treatment. So most fractures can be treated in lots of different ways. For example, a child who has broken their thigh bone, let's say a 5-year-old who's broken their thigh bone, I can think of 5 different ways of treating that, all of which would have very good results. What you need to do is to pick the method that is going to work. So you have to use a cast in a 2-year-old that you know is going to stand up to what a 2-year-old is going to throw at it. And if you think the cast can't do that, well, then you better pick a different method of treating the fracture. So you can't rely on controlling children. You have to assume they're going to put your treatment to the test, shall we say.
How do you decide on how to treat a fracture then?
I've kind of alluded to it. There are always options. And that's one of the things that really attracted me to this specialty when I was considering what to do. I love the fact that in orthopedics, it's very clear what the problem is. Unlike in other specialties where it's not clear what the problem is, you have to try and work that bit out. Once you've worked it out, the treatment is already decided for you. In orthopedics, particularly where fractures are concerned, we're usually pretty clear what the problem is. The interesting thing is, well, what are you going to do about it? Which of those 5 options are you going to pick? And I've always enjoyed the debate that went with that. And that's how we cut our teeth in surgeon school, is learning the skills that you need to decide on the right sort of treatment. So how do you decide on the treatment? You consider all your different options. You consider the age of the child, and you consider what is going to happen to this fracture if you leave it. So if you leave it, will it heal, and will it heal well? And can it go through this process of remodeling that I mentioned earlier? If it can do all of those things, then you want to pick the treatment that is the simplest and least invasive. Mm-hmm. If you can avoid an operation, it's definitely preferable to do that. Mm-hmm. And then there are exceptions, for example, certain hip fractures and certain elbow injuries in children where it's a no-brainer. They have to have an operation. Without an operation, bad things will happen. Okay. And then there are those fractures in between where you could play it either way. It's basically a lot of experience that you need to make those decisions.
Children, like adults, do they need physiotherapy? For instance, I had a knee arthroscopy as a result of a torn meniscus. I'm still undergoing the rehabilitation post-op. Do children undergo the same?
So there are many good things that come with age, like wisdom, but there are some bad things that come with age, like the need for physiotherapy. So for kids, life is one physiotherapy exercise, and it's comparatively unusual for kids after fractures to need physiotherapy because stiffness is just not a long-term problem for them. Mm-hmm. What is important, though, I have learnt, is to warn parents about what to expect after the cast comes off and I pronounce the fracture healed, a lot of people think, well, then how come the kid is still limping? How come they're walking with their foot pointing out? How comes they want me to pick them up all the time? That's all just part of the healing process, but physiotherapy rarely required, actually.
Mm-hmm.
And when it is required, then you need a specialist in the job, because if you, after your arthroscopy, you would have been told to go and do some exercises, which I am sure, Esther, you did absolutely religiously exactly what you were told, yes?
Of course.
Of course.
I had to follow everything to the letter.
Excellent. Glad to hear that. Your average 4-year-old is not going to do that.
Mm-hmm.
They're not interested in your reps and how long you're going to ask them to do these repetitive exercises. It's just not going to happen.
Mm-hmm.
So what you have to do is to trick them into it, to use play, basically. Trick them into thinking they're playing a game, but actually they're doing physiotherapy.
Okay.
But that's the subject of a whole other podcast. It is a fascinating area, actually. You see a good physio at work, it's a fascinating thing.
Again, talking about children and the need for physiotherapy. After my knee surgery, I suffered some muscle atrophy. Do children face the same thing? Especially knowing that they're not using one leg or arm or limb.
They do, yeah. They suffer exactly the same. In fact, there are studies which show even without a fracture, if you immobilize a limb, then muscle will waste away. It's true that, as you probably discovered from your physio, you can build it up again.
Yeah.
But if you like, it's the price you pay for using plaster casts and immobilizing kids. So I was talking about the different options there are for fixing fractures. So if there are children who you really don't want that to happen, for example, children who already have a muscle disease. For example, if a child with cerebral palsy comes who already has muscle weakness, if you treat them in a cast for a long time, that muscle's going to get even weaker. Similarly, there are children who are prone to developing fractures very frequently. They have brittle bone disease. Those kids would spend their life in plaster cast if you're not careful. So in those kids, we might pick a different method of treatment if we're really worried about muscle wasting. But for most normally developing kids, that's a price we're prepared to pay for the advantage of not having to do an operation for them. Mm-hmm. So it's, again, like I was saying, there are pros and cons to all these different methods of treatment. And, that's my job to get off the fence and make a decision about what I think is right for that individual.
Exactly. You're the doctor. So what are the latest treatments in the market for fractures? Yeah,
so there are a number of new implants that are available to us now in the last 10, 15 years that were not available before. I think children have always been considered not an important part of orthopedic practice, and what we had to do was do the best we could with implants which were designed for adults. In the last 10, 15 years, I think implant companies have got wise to that and have provided us with equipment that is specific for children. That's a big advantage. Bearing in mind what I already said, which is actually comparatively few children need complex treatment like that. So although there may be advances, for me, advances are not really what makes treatment good for fractures in children. Actually, old-fashioned treatment is great, provided it's done properly. And I made this mistake when I was a junior surgeon. I thought I wanted to learn about operations. I don't need to know about plaster casts. That's child's play, to coin a phrase. How hard can it be? Boy, did I learn pretty quick that actually plaster casts, to do them properly, to do them right, requires a lot of skill. And it needs help and it needs time. You've got to know what you're trying to achieve. And what's more, if you get it wrong, then serious problems can result that are quite difficult to get yourself out of. So you asked about recent advances. Yeah, recent advances are there, but the old school methods actually are applicable in children. And I do slightly worry that those skills die a little bit. Mm-hmm. That, as surgeons come through, they want to do the latest thing. Well, actually, the old skills work pretty well.
They're still in play.
Absolutely. But again, we talked about it a little bit at the start of the podcast about limb lengthening. So where the techniques really have advanced is not so much treating the fresh fracture, but from the problems that might arise from it, the complications, if you like, the growth disturbances. So we have much better ways of lengthening limbs in children now than we ever used to have. It's a far less painful process, a far less invasive process than it used to be. That's really where the advances are, I guess.
Okay. Doctor, I know you have a busy clinic, but before I let you go, I'd like to ask you if you're free to talk about it. Which is the strangest fracture in a child that you've ever seen in your entire practice?
The strangest fracture that I've ever seen? Gosh, I'd have to think about that one.
Something that really stood out. Up to now, you still remember it?
Well, there's a few of those. I guess a good example would be when I was on my fellowship in Australia. I was doing some specialist training there, and a kid had come who had no history of an injury, but had a painful leg. And we did all the investigations, couldn't work out what was going on. We did an MRI scan, and suddenly the whole leg lit up, and we were worried about all sorts of things that could be up. You know what it turned out to be? A fracture. It was just a simple fracture.
A simple fracture.
But the history was the child had been up to something that perhaps he shouldn't have been up to, so he didn't want to admit as to where this injury had come from. So that was a lesson to me that, as they say in medicine, common things are common. And if you're not careful, you can head down the route of imagining all sorts of weird and wonderful diagnoses, whereas fractures are common. So about 1 in 3 children have a fracture. You had a fracture as a child?
Never. I've never had a fracture.
You lead a sheltered life.
Yes, I'd say that.
It's not a bad thing.
What about you? Have you ever had a fracture?
Yeah, of course.
How many?
Yeah. Well, I don't know. Like, I think I lost count of them because of the sort of boisterous games we used to play. I'm pretty sure a lot of those were fractures. But ones I went to hospital with, just 2.
Just 2?
Just 2.
What about the others?
Didn't go to hospital. Just took my fracture and just carried on playing.
Animals in the forest, yeah.
Exactly.
All right, Dr. Spence, thank you so much for joining us today. So listeners, viewers, we'll be having Dr. Spence on a regular basis. So keep your eyes peeled.